All right, let's talk about something that trips up so many people on their coding exams. Chapter 18 of the ICD-10-CM. You know the one, symptoms, signs, and all those vague, ill-defined conditions. It seems simple on the surface, but wow, it is packed with tricky rules that can really make or break your score. So today we're going to crack that code, together.
So picture this, you're in the exam and you get this question. A patient comes in with chest pain. What's the code? Your first instinct is probably to just look up chest pain and move on. Seems easy enough, right? But hold on, in the world of medical coding, it's rarely that simple.
And that's the kicker. The correct answer is, well, it depends. It depends on a whole bunch of other stuff. What are the other diagnoses? Is this an inpatient or outpatient setting? What's the full story the medical record is telling us? This is exactly why this chapter gets so many people. It's not just about finding a word in a book. It's about understanding the rules of the game. So, to get you prepped for your test, here's our game plan. We'll start with the basics. What are symptom codes anyway? Then we'll cover the absolute golden rule of when not to use them. After that, we'll flip it and look at the exceptions, when symptoms actually take the lead. We'll even touch on a few complex conditions before we wrap it all up with a final exam cram session to make sure this stuff really sticks.
Okay, first things first. What are we even talking about here? In everyday life, we use the words sign and symptom pretty interchangeably. But in medical coding, nope. They have very specific, very distinct meanings, and you can bet your exam is going to test you on that difference.
Let's start with a sign. The magic word here is objective. A sign is something the doctor can see, touch, or measure for themselves. It's the hard evidence, a rash they can see with their own eyes, a fever they can measure with a thermometer, an abnormal heartbeat they can hear. It's a fact, no matter what the patient says.
Now, on the flip side, you've got a symptom, and the key word here is subjective. This is the patient's story. It's what they tell you they're feeling, things like dizziness or nausea or pain. A doctor can't see pain, right? They have to rely completely on what the patient reports.
So let's lock this in our brains right now. Sign is objective evidence. Symptom is subjective experience. Getting this distinction straight is the foundation for everything else we're about to cover. Okay, now that we've got our terms down, let's get to the rules.
All right, lean in for this one because this is probably the single most important concept in this entire chapter. It's the one that shows up on tests all the time, and it's where a lot of people lose easy points. I'm talking about the golden rule, knowing when you should not use a symptom code.
Okay, I know that sounds a little dense and official, so let's break it down. All this is really saying is, if a symptom is just a normal, expected part of a diagnosis that's already been confirmed, you don't code it separately. Think about it. If someone has the flu, you expect them to have a fever, right? The fever is baked into the diagnosis of flu, so you wouldn't add a separate code for it. It's redundant.
Let's look at a classic example. A patient has a confirmed gastric ulcer, and they also complain of abdominal pain. Now, it's super tempting to code for both things, right? But wait, abdominal pain is an integral part of having a gastric ulcer. It's expected. So coding it separately is just clutter. The correct, clean, and concise way to do it is to code only the gastric ulcer, just K25.70, and that's it. You're done.
Okay, so you've just mastered the golden rule of when not to code a symptom. So naturally, the next step is to learn all the times you're supposed to break that rule. Because yes, there are very specific, very testable situations where the symptom code isn't just okay to use. It's actually required as the main diagnosis.
So when does the symptom get to be the star of the show? Well, it's pretty simple actually. It's anytime there isn't a definitive diagnosis by the end of the encounter. If a patient comes in with chest pain and the doctor refers them to a cardiologist for more tests, what was the reason for the visit? The chest pain. If the doctor just can't figure it out yet, the symptom is the diagnosis for that day. It's the why behind the visit.
Okay, listen up because this is a guaranteed question on your exam. The rules for uncertain diagnoses are completely different depending on where the patient is. In an inpatient hospital setting, if the doctor writes probable pneumonia, you go ahead and code for pneumonia. But in an outpatient clinic, probable pneumonia doesn't count. You can't code it. You have to code the signs and symptoms instead, like cough and fever. You need to get this one down cold. Inpatient probable is okay. Outpatient, it's a no-go.
All right, so we've nailed the everyday rules for signs and symptoms. Now let's level up a little bit. Chapter 18 also covers some more complex situations, like coding for a patient in a coma, which requires a very specific sequence of codes that you've got to get right.
So, when a patient is in a coma,
It's not enough to just say coma. We need to communicate how severe it is. And the main tool for that is the Glasgow Coma Scale, or GCS. It's a standard system for measuring a person's level of consciousness, and guess what? It has its own special codes.
Now, here's the really important part. The GCS score isn't just one number. It's actually made up of 3 separate parts. The doctor assesses the patient's eye-opening response, their verbal response, and their motor response. And for your exam, you have to remember you don't assign one code for the GCS. You have to assign 3 separate codes, one for each of those components.
This is a sequence you just have to memorize. It's like a recipe. You have to follow the steps in order. Step 1, you code whatever caused the coma, like a head injury. Step 2, you assign the code for the coma itself. And finally, step 3, you add those 3 separate codes for the GCS scores: eye, verbal, and motor. It's a whole package deal.
And hey, you'll see this same kind of logic in other areas too. For example, with acute stroke patients, doctors often use the NIH-SS stroke scale to measure the severity. And just like with the GCS, when you see an NIH-SS score documented, that's your cue to use a specific set of codes from subcategory R29.7. It's all about adding as much specific detail as you possibly can.
Okay, we have covered a ton of ground, so let's bring it all home and boil it down into a super fast final review. This is the stuff you absolutely positively have to know before you walk into that testing center.
Here are your 5 commandments for Chapter 18. 1. Got a final diagnosis? Don't code the built-in symptoms. 2. No final diagnosis? Then you do code the symptoms. 3 and 4, the big one. Inpatient means probable is codable. Outpatient means it's not. And 5, coma coding is always a sequence. Never ever just one code.
I'm going to say this one more time just to really hammer it home, because it's that important. For inpatients, and only for inpatients, words like possible, probable, or suspected are treated as if they're real, established diagnoses. You will code the condition itself, not the symptoms. Burn this rule into your brain.
Okay, last chance. A little pop quiz to see if you were listening. True or false? A symptom code from Chapter 18 is never used as the principal diagnosis. Lock in your answer. What do you think?
And the answer is a big, loud, resounding false. Of course it can be. Like we just talked about, when there's no definitive diagnosis by the end of the visit, that symptom is the reason for the encounter. It absolutely becomes the principal diagnosis. It all comes back to the context.
And really, that's what this is all about. These aren't just random rules designed to make your life difficult on a test. They are the grammar of medical storytelling. Mastering this chapter means you can tell a patient's story accurately and clearly. It's about more than just passing an exam. It's about making sure the medical record makes sense. You've got the tools now. Go get them.